So thank you to all of the speakers on this panel. That was some great things. We want to open it up now to questions. As you know, there's microphones on each side of the room. We have no questions online at the moment yet, but we welcome to send some in. Okay, it must be that post-lunch processing that folks are going on. There's so many interesting things that you all brought up, but since Alice you went last, I'm struck by your ability to collect the data that you have access to, and so I wonder from an organizational perspective, how were you able to adopt, to get all of those things into your EHR and then get everyone to use the EHR appropriately to gather that information? It's actually down below.
Yeah. It's not the green button.
I know.
So actually the slide I showed you is aspirational. We're actually in the process of building that out. So we've actually tailored our instance of the EHR to actually be specific to our patient population in terms of collecting needs. But I was just going to say, just some of the basic data elements around kind of language, race, ethnicity, sexual orientation, gender identity is actually the work we've been doing in terms of data collection in order to then be able to risk stratify our outcomes and figure out how do we do interventions that really target specific groups and reduce disparities. And I think that's actually something that I would say has a link to policy, which I know is the next panel, but we really push to have the Medicaid waiver include a pay-for-performance element that actually was around that kind of data collection, just as a best practice.
I think it's true that sexual orientation and gender identity are in many EHRs, but they are being underused, that people have to be trained to use them and to understand that people want to be asked. I don't know if any of you saw, there was recent research about an emergency department, and they asked LGBT people, if you were asked about your sexual orientation, gender identity, would you answer? And 90% of them said that they would, and that's a very vulnerable place to be, the emergency department. Then they surveyed the providers, and 77% of them said, no, I won't ask, it's too intrusive, they won't tell me. So that is a serious disconnect, the short answer being, do ask, we want to tell. And I wonder if, based on what you were saying, Alice, that some of the reluctance is, I don't know what to do with it. If I ask questions about housing or food insecurity or gender identity, what are you going to expect me to do once I know the answer? And I don't know what to do, or I don't have time to do anything.
Yeah, I just will add that you're exactly right, that when we first rolled out our collection of SOGI data, we got feedback from actually not the providers, some of the frontline staff. So we're actually trying to just normalize it as part of the registration process. Got a lot of pushback, and we actually went to our patients and brought that data back exactly as you said. Actually, people want to be asked, and actually ended up having to do a lot of training around that.
Yes.
Some video-based, some in person, to get people comfortable doing that. But that's exactly right. You can't just, it's not an out-of-the-box thing.
Right.
No. Yes.
Yeah, I was going to speak to what you were just speaking to.
Yeah, can you say your name?
I'm sorry, Judy Salerno, New York Academy of Medicine. I recently met with a group of medical students from across New York City who came to us and to say that they were really worried about their education because they confronted with the issues that their patients, that they knew impacted their patients' health, like housing and food, that they felt A, helpless, and B, that, that they were not getting anything in their curriculum that would help them figure out how to be advocates for their patients. So they felt really shortchanged by their education. And they put together a meeting where they had 250 students from across the city show up on a Sunday morning at 8 o'clock, which is really remarkable, to really discuss these things. And my question is that, moving forward, this was a wonderful one-day event, but I would like to think about how we can can really help support students and people in training to be healthcare providers to really empower them to help empower their patients so that they can really confront the things that that really have an impact on health that are outside of what is in their current armamentarium.
Can I just add on to that for a second? Yeah. Phil Pizzo from Stanford. So I was going to make a similar comment to yours, Judy. I can't think of a IOM or NAM panel that I've participated in over the years that hasn't addressed the failure of teaching providers appropriate communication skills. You know, it came up from the very beginning of today's session all the way through every presentation. And I think it is just a systemic failure, you know, in our educational processes in terms of not the beginning of medical school, but the sustenance of what happens as time intrudes on the ability for people to interact with their patients in meaningful ways. And, you know, I don't know, and Judy, you may know this, whether we've focused on this singular issue in its own right with, let's say, the National Academy, because I don't know that we're going to resolve it by asking each of our panelists today, what would you do? Because it's such a huge problem. It requires a major, major effort. You know, and I just want to call that out. And I'm so pleased that you brought up the comments you did about what's happening in New York, because at least it indicates that young people starting their careers see this as a real issue that we're failing to deliver.
Can I just make a comment? And just in terms of like the enormity of health-related social needs, I think I have a couple thoughts on that. One is it is critical for future clinicians and healthcare professionals to be aware of this, because honestly, a lot of times someone's coming in with their blood pressure, but really what's their more pressing issue is their food insecurity or housing or immigration status.
Yeah.
But secondly, it is not incumbent on either that individual provider or the healthcare system to fix it. I think to Marshall's point, number one, it has to be a team-based approach, which is what we're trying to strive for in the clinic. And then there have to be community-based partners. So in your local community, there has to be a will to support those other resources that actually do provide the housing and the food and things like that. And then I think on a macro level, and I think this is a challenge for all of us in healthcare, is how do we shift the spend ultimately from healthcare into some of these other areas vis-a-vis, you know, Betsy Bradley's work, where we know that actually $1 spent in early educational interventions and poverty reduction is going to get us a bigger bang for health than just putting it in our hospitals and clinics.
Yeah, no, I agree with that. You know, but it's also important to note that in virtually all the different IOM or NAM recommendations, there have always been comments about how credentialing, education systems, accreditation systems should impact on education. And, you know, here we are decades later, and we're still calling out the same problem.
So I think I really appreciate the comment about the students, and it takes me back about a decade and a half when I was really involved with the American Medical Students Association, who was very focused on all of these issues. And when I would take some of what I learned in my meetings here in Washington or across the river back to my institution, there wasn't a lot of interest. And so there were that sort of small group of medical students who were very focused on social justice issues, who would come back and take that first step of being educated about it, and then come back to a system that really prioritized their test scores on the anatomy exam above all else. And so I think that one is a problem of connecting people who are doing the work and have the opportunity to sort of, who have been thinking about this, and another is, again, looking to the medical schools to change their priorities to some extent.
Yeah, you know, I would just say the American Medical Student Association did a great job on conflict of interest issues. They really rose to that in a significant way. And in fact, the same students for us changed all of our guidelines years ago on how we handled LBGT issues. So yeah, young people just like yours can make a difference. We just need to find ways of making that, you know, continue, not get lost.
I just want to say that As a licensed clinical social worker, I'm delighted that the answer is not call the social worker. It is what social workers do, or some social workers do, but it's not going to be fixed by the social work department alone. And I think for a long time, all social issues have been pushed over to the social worker and not integrated into the delivery of care. So thanks.
Yeah, I started out my career at a medical school, and I developed their communication skills course. And at that time, it was kind of the phase that medical education was going through. You know, now we're going to all develop communication skills courses, just similar, I think, using my armchair observation, now that we're talking about, now we're going to make sure all of our students are trained on the social determinants of health. And I think one of the things we have to do is make it a little less what's the shiny right now, and make sure that we're continuing, because, you know, it's a finite number of hours that the med students have. And I get that, but we have to use that time creatively. We have to use that time to embed all of these things, to embed that equity lens, to think about communications, and to make it not necessarily, in my Darcy opinion, make it not necessarily an add-on course. It's not the communication skills course that you took in year 1 or year 4 or whatever, and then you're done. You know, when you're taking your cardiology rounds, when you're in obstetrics, you're learning about equity, you're learning about communications, you're learning about the social determinants within that lens. So it's always this both and rather than this either or. But there you go. But we have another question.
Eddie Mochtinger from UCSF. Just really following on that exact point, there's been a thread throughout the whole day that the lived experience of patients, either through discrimination or poverty or individual and family level trauma, leads to disparities in health outcomes, and those same individuals face communication barriers once they are accessing care, which just further prejudices them in terms of their health outcomes. It's also obvious that our health system is not going to be able to solve everything. Like, we will not be able to singularly as a sector fix this problem, but we have a role to play, and we need, I think all would agree, to step up and play that role. And my question is, there are many names for some of the very similar concepts that we're bringing up today: health equity, health disparities, communication, trauma-informed care, integrated care, whole person care, complex care. And I wonder, from a strategy perspective, if we feel passionately about our sector stepping up into this realm and serving our communities better, if we can be more strategic about how we align our various movements towards the same goal, and if there is a process in place that's already thinking that way.
Thoughts?
My experience, just even in one health system, is people are very wedded to their particular conceptualization and verbiage. And in truth, like when you actually dig down, it's not quite as aligned as you may think when you talk about it. And at the same time, I do think there is this convergence around kind of larger structural issues and figuring out how the interplay between that and individual impact on health, and like some of the policy and programmatic solutions to that. So I think it's harder than it might seem.
I also think there's, as it relates to communication in health systems, I've sort of thought of as a little bit of a Trojan horse approach, in that systems want to improve communication because they want to improve the quality of care for their patients. They also recognize that if we provide more care that aligns with what people say they want at the end of life, let's say, which is more comfort-focused care, that they'll actually save money on things like readmissions, and that will help their bottom line in a value-based care system. So we can convince them of the value of, implementing systems that improve communication across the system, and I can, have my intention be that it addresses health equity or health inequities. What would be a great next step is to have systems take that on board as a primary value rather than something else. And I think that's, part of our work, the sort of moral leadership of this institution in some ways, hopefully.
I'd say actually I think that's the larger challenge, is that all of this recent influx of interest in health-related social needs, individual level social determinants of health, communication, and of life care is really driven by ACOs and cost savings, right? I mean, you saw the Medicaid pilot, their actual evaluation metrics are around ED, hospital, and SNF use. And the question is, how do you use it as a Trojan horse and not go down a rabbit hole and end up somewhere you don't anticipate being, and really remembering to keep that the real frame should be around social justice and equity for society, and not just look under the lamppost. I think that is the real trick, because right now we have an opening. It's just that where does that opening lead us?
Yeah, and I'll just follow up. I don't think there's a simple answer to that question, and I appreciate that it's nuanced, but I would invite also the policy panel to consider the strategy of growing these efforts so that we don't duplicate kind of efforts. And I'm affiliated with trauma-informed healthcare, but I am by no means wed to that term. I would say that from my field. But I would love to insinuate this conversation about strategy and points like you're saying about wisdom about the ACOs and other drivers, exchanging drivers, that can further our mutual goals.
Yeah, thank you, Ed. As someone who has spent numerous hours debating whether it should be cultural competency, cultural sensitivity, cultural humility, cultural appropriateness, and all of those things, I think if we can get to those strategies and we can get to the what we're trying to accomplish part, rather than, it's important to name things, but we have to move on action and not get paralyzed in that what we're going to trademark it or hashtag it. Yes.
Hi, I'm Ann Kellerman. I'm a palliative social worker at Washington Hospital Center here in DC. And I loved what you said about chronic bias being a chronic illness that needs to be controlled. And I was wondering in any of your trainings if you're speaking to the bias that often is played out in documentation, and if there's any sort of training that's being developed around that as far as how we can better document and control a lot of the bias that I see that comes out when you're reading notes or.
Do you mind sharing some, like a specific
Sure. So
example?
I've
I'd love
seen
to
bias
hear.
around, incorrectly documenting a gender of a patient, if it's a transgender, not using the correct pronouns, some bias that follows around non-adherence or non-compliant, and, may not actually be true, and then that becomes a part of somebody's permanent, medical record. Or in the first line of an HPI, some, bias around judgments around where somebody might live or, that might be more appropriate in the social history. Yeah. And I think that's often sort of a bias of, I'm not sure. And I just was wondering if there's any sort of thought that's put into that. Because then I think that's read or that's traveled along, and then you sort of have this informed idea when you're addressing patient care.
I love this question. I think that we haven't addressed that specifically. I think the way we teach people to document is to document the things they've heard. And what you're raising is the possibility that things they've heard are colored by their own experiences. And I think that's a really powerful construct. I think that, for instance, we will do well when we abolish the word compliance from medical documentation, period. I'd like to think of compliance in the physics sense, which is the pressure, the phenomenon of a force acting on a vessel, right? And the force is the force that we bring with us in our the power differential from doctors to patients, and we expect them to comply in some way. And really, what we should be working for with patients is adherence to plans that are aligned with what's important to people. And so that would be a great first step, I think, if we can sort of think about some of the language that we sort of commonly use in healthcare, and then try to be as faithful as possible in getting people to document the things that matter most to people.
Mm-hmm. Yeah, thanks.
Yes.
Hello, I'm Marian Grant. I'm a palliative care nurse practitioner and policy consultant. And I just wanted to go back to the question about training clinicians, because I am a former nursing school faculty, and I taught first semester nursing students communication. They were so earnest. They were so eager. They were lovely. And then we beat it out of them. Yes. I practice in a large academic medical center where I hear horrible conversations daily by senior staff of all disciplines saying egregious things to these young learners. And so, I mean, we can do all we want in medical school. We can do all we want for the social work and nursing students. But what can we do to address this chronic bias and to, you know, the hidden curriculum is more overwhelming than anything we can teach them in the limited hours we have, where we also have to teach them 100 other things. So I just would be interested in the panel commenting on that.
It's something we've thought a lot about in our communication skills training, and I'm influenced in my thinking by Susan Block, whose experience was you can train medical students all you want, and the image that comes to mind is sort of the shark model. Like if you don't have bottom teeth and you just have the top, like you're not going to eat it. And if you train the bottom, you know, you really have to do both from both sides. And because, as you said, like when students, earnest, excited, engaged, willing to take things on, enter an environment in which those things are not valued at all, and what is demonstrated is the opposite, they just forget it, and or you know, shamed into not using it. And so figuring out how to do both, and I think this is, you know, in part probably some of the reason, and James could speak to this, why Vital Talk really targets mostly, you know, clinicians in practice, because it's about changing that practice, and ideally those things filter down or come from both directions.
I see that we're talking a lot about like the skills of communication, and I think we can't separate, or we do better to not separate that out from both knowledge and attitude change. And that when we do cultural competence training for health and human service providers, the curriculum is based on, I mean, knowledge is easy to change. You can teach people how to say the right thing, but it's really the attitude that's going to make the biggest difference, because especially as I was saying earlier, in my community where the language changes all the time, don't memorize that. Like, care to know, and someone will tell you what the newest word is.
I was going to say, you know, I think honestly training obviously only goes so far, and I think, you know, then there were the attempts of HCAPs and CGCAPs. Can we get for us, actually bringing the patient in and hearing, having frontline teams hear patient experiences as part of regular, you know, we're a lean organization, so we do Kaizens, we always have patients there. And I just still remember the very first one we had our chief nursing officer and our CEO, and we had a patient, and our consultant asked, like, you know, how does it happen when someone comes to the ED? And the CNO was like, oh, well, you get checked in, you get vitalized, you get, like, here are all the steps. And the patient literally was like, are you talking about this hospital? Because I come here all the time, and that has never been my experience. And in fact, I will go out and call 911 to get, you know, whatever. It's like, and just like having that reality check and hearing from patients directly about what they've experienced, including, and it's hard to get patients to actually share their negative experiences. Frankly, they fear retribution. They, you know, don't want to embarrass people. But I think in our experience, that's been really, really powerful to bring in patients directly and have people hear from them, which sticks with people more.
Yep, Marshall?
So Marshall Chin, University of Chicago. It's a question first for Liz, and then open up to the rest of the panel. That you used the concept of intersectionality on one of your slides, and you mentioned like a variety of different dimensions, so sexual orientation, gender identity, class, et cetera. So in some ways there's this richness, but oftentimes we don't really talk about it. And part of it maybe just we don't have as much time, or we focus upon like the immediate. So 15 minutes, for example, is really hard to cover just the basics of like LGBTQ issues, intersectionality. So I'm wondering, like, what have you found to be effective then when you're trying to either teach or instill in sort of system solutions a more intersectional approach? Because again, I feel like it's been like a challenge throughout the day that you only have 15 minutes, and so people tend to focus upon like their main topic. But in reality, intersectionality cuts across just by basically every speaker's talk. But in some ways, we haven't really given it the richness or depth of conversation that would be ideal. So what suggestions do you have then in terms of like us more effectively addressing the intersectional issues raised by all of your talks?
I don't have a clear-cut guideline for that, and maybe I'm just going to fall back on what I just said previously about attitude, but it's a way of understanding people as not being reduced to their socioeconomic class or their race or their health status or their sexual orientation and gender identity, but understanding the complexity with which all of those experiences determine our experience of healthcare and the world. So you don't have to spend a lot of time on it if you just keep that in mind, like knowing you're seeing a gay man. Not all gay men are the same.
So
did that help? Probably not.
I'll piggyback on that. And I had that Venn diagram of, when we're examining culture, because I found, and that's a model, quote unquote, that I started when I was teaching at the medical school, because what I saw was folks were talking about race, and then they were talking about ethnicity, and then they were talking about language, and they were talking about sexual orientation, and they put them in the little boxes, and they tied them with the little bows, and nobody was talking about how culture is lived. And so when I talk about cultural competency, because I didn't have, I'm not sure where she went, the earnest, medical students. I had the medical students who said, I've been talking my entire life. I don't need this communication skills course. Thank you very much. And they're like, you're trying to turn me into an anthropologist. And I'm like, no. I want you to learn the questions. I want you to learn to care. And what's important is not all of the terminology, but asking the core questions that get you to the heart of that patient. What brings you in today? Why today as opposed to yesterday? What are you thinking about this? And if you have the right set of questions and they're framed in the proper way, the intersectionality, I feel, in many ways will come out of the patient. And it's just something that, again, we have to kind of bake into our system and process. Alice, or Justin?
Oh, do you want to go?
Sure, I'll go. I think one of the things that's challenged, so I've found intersectionality to be an incredibly useful construct, and it's, as I understand it, sort of at the core of intersectionality is the idea of multiple sort of overlapping oppressions, but oppression is an important feature, and I think that's hard, and I think it's hard for students and others to take on board because it's overwhelming as it is for the people experiencing it in some way. And I wonder, I've wondered sort of how we think about, thinking about concepts of privilege over intersectionality in ways that, without whitewashing them, help people connect to the human experience of others. And so that's an aspirational goal, but I think that that's one of the challenges with the construct of intersectionality.
And what I'd say, Marshall, is that the quote that leapt into my mind in hearing your question was the one that I wouldn't give a fig for simplicity on this side of complexity, but I give my life for simplicity on the other side of complexity. And what I mean by that is just saying, oh, treat everybody like a human. Like, that's simplicity on this side of complexity. Once you understand all of the drivers and all of the issues and actually are sensitized to them, and you can't possibly anticipate all of them, being on the other side of that and being open and curious and following the patient, I think, is how we get there.
I just want to say one other thing. It's so great to be here this afternoon and have this discussion, because this morning I did a 2-hour cultural competence training for 365 dentists, because in order to renew your license in DC, you have to have 2 hours of LGBT cultural competence training. So when I got to a whole section on intersectionality, I said, show of hands, who has ever heard of that word? Not one. Not one. So thank you. I mean, we can debate it, but at least we're thinking that way a little bit.
I think it's actually a really good suggestion, the one about, the concept originates from Kimberly Crenshaw, right. African-American feminist, and it is like these interlocking systems of oppression. But in some ways, that's been one of the themes of the overall talk in terms of thinking about the individual and patient care and the systems and social drivers together. And so it is a more complicated discussion, but one that ties together nicely the different topics that we've been talking about. Yeah.
Yes, thank you. And yes.
James Tulsky, Dana-Farber Cancer Institute and Brigham and Women's Hospital. So first of all, thank you to all 3-4 of you for your talks. My head is sort of swimming with everything that's there, and they were wonderful and stimulating. So one sidebar comment, then I want to get back. So the sidebar comment just has to do with this whole idea of why don't they learn it in medical school? And, we could have a very long conversation about this. I think that one of the things we need to own is that we've never taught it well. and that some of it has to do with trying to make people better people. And there's a lot of that that infuses the current teaching or has infused it historically. And in fact, the teaching of communication skills has historically not been particularly learner-centered. And so just as well as we talk about the centeredness of any of this, we have to think very carefully about how we teach adult learners these sorts of things. And we could have a large conversation about that. But I wanted to bring something back. I wanted to come back to the idea that this whole conversation, which is rich and important, is for this particular conference in the setting of serious illness. And it's in the and the roundtable is, quality care in serious illness. And so I want to come back to that as a lens for a moment, because what I've noticed is that there have been, in my lifetime, the people, whether they were medical students or residents or whether they were other health professionals who were interested in sort of the kinds of things and the kind of sentiments that are being expressed here, gravitated to certain places. So back like a long time ago, I remember people gravitated toward geriatrics for this. And then they gravitate, I'm even thinking about my own history, gravitated toward general medicine for this. And then when palliative care, serious illness care came along, we gravitated toward that. So those are the people, and I see them come to me, the students, the residents, whatever, they come to our programs because they're looking for this. They're looking for this thing. They're looking for connection and human, touch. And so they come to us to try to find it. And so here's the challenge and maybe the question that I want to put out there, which is, it's such a big issue. Can we use serious illness care as our pilot, as the place that we work on these kinds of things? In general, I would argue that those of us who do this for a profession are pretty attuned or more attuned to some of these issues. We're not perfect. We're more attuned perhaps than the general larger population. And it's a little bit smaller to be able to focus on, and there are lots and lots of programs that are already focusing on it, that are already focusing on, a lot of different things and are already working as sort of teams around some of these kinds of issues. So the challenge is, can we make this a part of programs, models of care that we're building around serious illness and try to break down some of these barriers and try to infuse this in a more real way, and then hope that it bubbles up backward to, when the patient walks in the door of the cancer center to start with. Maybe they really get this high quality care when they're a lot sicker, but could we have changed it earlier on? So I just want to throw that out as a possible model.
So I think that, for example, goal concordant care, as problematic as it is a great example of that. Like I remember being a primary care doctor and trying to convince someone that they had high blood pressure so that I could convince them to take medicines. People don't care about having low blood pressure as a primary value. They don't feel it at all. What they really want to do is watch their children go old. And when you can convince them that part of the thing that would get in the way of that is having a heart attack or a stroke, then you're starting with the things that they value most in life and moving backwards sort of upstream to getting to the place where maybe treating your blood pressure is actually going to facilitate this goal. It's not, who cares if it's like, I get excited about the next time your blood pressure is low. And so I think that's just one example of ways that we can start to prioritize the things that matter to patients and open up this whole space around driving medical care that is based on the things that matter most to patients. And I think we've done the most work in that realm so far, and I think we can continue to push to find those outcomes and hope and then push them upstream.
Okay, we're actually at time, but we'll take one more question.
Actually, this is just a comment. Hello.
Okay.
Thank you, though. So Kim Lee, scholar at a GW at the intersection of art, aging, and healthcare. And so the comment really is based on a funded research that I was part of.
Can you speak more into the microphone?
Funded research from NIH that was based on patient-provider communication, specifically in wards 6, 7, and 8, who have the highest diagnosis and death for young African-American women with cancer. And what we found in the outreach team, just to piggyback off of the gentleman's suggestion of a model of preventative care, what we found really was the trigger that made the difference in the communities in these certain wards were empowering them with their own data. And I'll give you an example. So traditionally, NIH or Johns Hopkins would come in and they do like a $25 giant card or something they thought was in a food desert, or so some of the social determinants that were more visible. And the patients or the potential patients being part of the study took the giant food card and then left and didn't finish the 6-week program. But 3 weeks into that, and we got an extended, what we found out was a different monologue of what healthcare looks like in their own community and sharing the history of that, specifically in Anacostia. For example, if you're African American, you have 12th grade or lower education, you have any history of diabetes or hypertension, you have almost a 70% chance of getting Alzheimer's and dementia. And that was a game changer. That started the narrative about their own stories, about their own community, about their own families, whether present or dislocated. So I encourage them to participate in their own health care and get their data and make sure that they are treating that as part of their story, because that makes a difference. So I just wanted to share that with you.
Okay, thank you very much. With that, I just want to thank my esteemed panel. Once again, another amazing session. Yes, indeed. We now have a break. Please be back at 2:45 so that we can start the next session. Thank you so much.